My patient fought his insurance company for 3 weeks to get an MRI approved. I did a peer-to-peer review with the insurance doctor. They finally approved it. Then he called me, furious. His copay was $500. I said, I told you so. Because here is the thing nobody wants to hear. The MRI does not cure you. It just tells me what I already know. And today, I'm going to explain why that $500 scan might be the most expensive picture you never needed. Welcome to your daily health briefing. I'm Dr. Albert Takem. This show is here to help you navigate the complex U.S. medical system, one step at a time. Whether you are decoding a new diagnosis, fighting for a referral, or just trying to stay informed, you are in the right place. Let's get into the science. Marcus is a guy in his 40s, strong, works out, active lifestyle. He came to me with neck pain that was shooting down his arm. Classic presentation. Pain starts in the neck, radiates down one arm, maybe some tingling in the fingers. So I examined him. I knew exactly what it was. Cervical radiculopathy. You know, that's a fancy term for a pinched nerve in the neck. So I told him, Marcus, I know what this is. Let me give you some prednisone to calm down the inflammation. We'll get you into physical therapy, get some Tylenol or ibuprofen. He said, no, doc, I want an MRI. I need to see what's going on in there. I really want to find out. So I explained that the MRI wouldn't change what I was going to do for him. He would still get prednisone. He would still go to physical therapy. And if he didn't get better, he would see a spine surgeon who would also send him to get physical therapy first. The MRI was going to show a bulging disc pressing on a nerve. I already knew that from examining him. The MRI would just be a $500 photograph of what my hands already told me. But he insisted. Insurance denied it, of course. I did a peer-to-peer. That's when, you call the insurance company's doctor and argue the case. So they finally approved it. Then Marcus found out his copay was $500 and he called me furious. So I said, Marcus, I told you this would happen. But more importantly, I need you to understand something. The MRI does not cure you. It's a diagnostic tool. It tells us what is wrong, but we already know what's wrong. What you need is treatment. You need to feel better, and that treatment is prednisone and physical therapy, not a picture. Now, I had another patient, let's call her Kim, who came in with shoulder pain on both sides. She couldn't do push-ups, couldn't dry her hair without pain, and she told me she had been reading online that her shoulder pain was caused by estrogen loss from menopause. She had found articles. Her husband, who's also my patient, told her that was nonsense. So I told her, I think your husband is right. I examined her shoulders. She had full range of motion, no loss of function. The shoulder joints were fine. This was muscular, just simple old-fashioned deltoid pain, likely from overuse and the natural healing timeline of musculoskeletal injuries. So I told her, give it time. Find exercises that don't aggravate it and stop reading the internet for diagnosis. But she asked, Doc, but don't I need an MRI? So I said, what would the MRI really change? If it shows inflammation in the deltoid, the treatment is still rest and time. If it shows a partial rotator cuff tear, the treatment is still physical therapy. The MRI doesn't change the plan. It just costs you money and gives you anxiety about findings that may not even be related to your pain. So, as I say that, let's get into the science, because this is where things usually get dicey for patients and it becomes a huge problem. Let me give you the data, because this is one of the most important things patients don't understand about modern medicine. MRIs find things in healthy people. A landmark study of 1,211 completely healthy volunteers, no neck pain, no symptoms, nothing, found that 87% had disc bulging on MRI. Even among people in their 20s, over 73% had bulging discs. A classic study published in the Journal of Bone and Joint Surgery found that 19% of people with zero neck symptoms had abnormal cervical spine MRIs. 28% of those over age 40. These people felt completely fine. Their MRIs looked terrible. The ACR, which is the appropriateness criteria, those are the guidelines that radiologists use to determine when imaging is appropriate. It states explicitly that MRI is frequently positive in asymptomatic patients. Detected abnormalities are not always associated with acute symptoms, and abnormal levels on MRI do not always correspond to abnormal findings on clinical examination. What that means is you find something bad on the MRI, you don't find anything bad clinically in the patient. In one study of 98 patients with cervical radiculopathy, that is pinched nerves, the agreement between where patients felt pain and what the MRI showed was poor. That is, they had a pinched nerve on the neck on the MRI, but it did not manifest in symptoms in their body. So what does all this mean? It means if I MRI your neck right now, there is a very good chance I will find something. A bulging disc, a narrow foramen, some degeneration. But that something may have been there for 10 years and has nothing to do with your neck hurting today. And now you are worried about it. And now you want another scan in 6 months. And now maybe someone suggests surgery for a finding that was never causing you symptoms to begin with. And another important thing is that MRIs increase cost without improving outcome. Because let's face it, when you do an MRI for one reason, you find something that is benign, that was not causing any problem to the patient, and now you tell the patient that they have a problem in the neck, and the patient becomes obsessed with that, cannot sleep because he's worried. You, the doctor, just told them there is something in their neck. And even though to you, the doctor, it is something benign, to the patient, they cannot stop wondering if that something benign is going to turn out to be something big, just as their cousin 2 years ago was told that the little thing in his back was nothing and it turned out to be cancer. Going back to the cervical spine specifically, the ACR guidelines state that for acute neck pain with radiculopathy and no red flags, MRI is usually appropriate, but not as a first-line test. The first line is clinical examination and a trial of conservative therapy. MRI becomes appropriate when symptoms persist despite treatment, when there are progressive neurologic deficits like an arm getting weak, muscle atrophy, that's meaning muscle getting thinner, or when surgery is being considered. So let's ask the most important question then. When do you actually need an MRI? So an MRI is essential when there are red flags. That is, signs that something more serious is happening. These include progressive weakness in the arms or legs, loss of bladder or bowel control, that is, you urinate on yourself or you lose control of your bowels and you defecate on yourself. There are signs of spinal cord compression, history of cancer with new spine pain, fever with spine pain suggesting infection, or symptoms that are getting worse despite treatment. An MRI is also appropriate when surgery is being planned, of course, because the surgeon needs to see exactly where to operate. That's the MRI's job. It's a surgical roadmap, not a diagnostic shortcut. And going back to the shoulder estrogen question, now I want to address Kim's concern about estrogen and shoulder pain because this is circulating online and I had to go look it up myself. There is actually some emerging research suggesting an association between sex hormone deficiency and rotator cuff disease. So for completeness sake, a large database study found that women with estrogen deficiency had a 48% higher odds of needing rotator cuff repair. And estrogen receptors have been found in the supraspinatus tendon tissue. But And this is critical, very important. Association is not causation, meaning just because two things are associated does not mean one is causing the other. The research is purely observational. We do not have any clinical trials that have shown that estrogen replacement prevents or treats shoulder pain. And in Kim's case, our examination showed normal shoulder joints with full range of motion. Her pain was muscular, not structural. This estrogen theory, even if it has some biological plausibility for rotator cuff degeneration, did not explain her specific clinical picture. Her husband was right to be skeptical, and in Kim's case, she works out a lot. She does all sorts of body weight training. So consequently, it is normal that she can experience pain in her muscles. That's kind of the whole point of working out. This brings us to the most important part of the episode, patient-physician allyship. Because I understand why patients want MRIs. You are in pain. You want answers. You want to see what's happening inside your body. And in a world where we have incredible technology, it feels wrong not to use it. But here is what I need you to understand as your doctor. My job is not to order every test available. My job is to order the right test at the right time for the right reason. And sometimes the right answer is, we don't need a test. We need treatment. When I examine your neck and I feel where the pain is, when I test your reflexes and your strength and your sensation, when I reproduce your symptoms by moving your head a certain way, I am gathering information. Actual intelligence that is just as valuable as an MRI. Sometimes more valuable, because my examination tells me what's causing your symptoms right now. The MRI tells me what your anatomy looks like, which may or may not be related to your symptoms. I am not trying to save the insurance company money. I am trying to save you from unnecessary anxiety, unnecessary procedures, and unnecessary costs. Because once you see that MRI report, once you read disc herniation or degenerative changes or foraminal narrowing, you can't unsee it. And now you are worried about something that might have been there since you were 30 years old and never caused a single symptom. Medicine is not about pictures. Medicine is about listening, examining, thinking, and treating. The MRI is a tool, but it's not the only tool, and it's not always the best tool. So, as we wrap up, if you remember anything from this episode, let it be these 5 things. Number 1, an MRI does not cure anything. It is a diagnostic tool. If your doctor already knows what's wrong based on your history and examination, the MRI does not change your treatment plan. Number 2, MRIs find abnormalities in healthy people. Nearly 88% of people with no neck pain have disc bulging on the MRI right now. If you scan enough people, you will find something in almost everyone. That doesn't mean it's causing your pain. Number 3, musculoskeletal injuries take time to heal. Shoulder pain, neck pain, back pain, these are not emergencies in most cases. They require patience, physical therapy, anti-inflammatory medications, and time. Weeks to months can pass by before that pain heals. Sometimes even longer. An MRI at week 2 doesn't speed up healing. Number 4, ask your doctor, will this MRI change what you're going to do for me? If the answer is no, if the treatment plan is the same with or without the MRI, then the MRI is $500 photograph that gives you information but not healing. Number 5, trust the examination. When your doctor presses on your shoulder and moves your arm and tests your strength, that is medicine. That is thousands of years of clinical knowledge applied to your body in real time. It's not inferior to a machine. It's the foundation that tells us whether the machine is even needed. Save the MRI for when it matters and trust your doctor to know when that is. I'm Dr. Albert Takem. I will see you on the next one because the fight for your health doesn't stop. This has been the Daily Brief. Medicine is not about certainty. It is about responsibility. Decisions are often made with incomplete information, but they are always made with your safety in mind. In a system that can feel rushed and fragmented, you deserve clarity, continuity, and an advocate who sees the whole picture. I am Dr. Albert Takem, your physician ally, high-level science, human-level care. I will see you at the next briefing, or I will see you in the clinic.